Thank you so much, Amish. Thank you so much, and I thank both Amish and also Parvish sir. Basically, because if you are bound within some perspective, you swim with, you swim within a pond. Here it's a jar. But what Amish and Parvish sir has taught is to think beyond, swim beyond, and then the ocean is the limit. So I must thank both of them to put up this concept, and great opportunity to be here. I will just reverse the order of the some of the data, if you allow me. So the first one I'm going to go is the Topaz 1 trial. As you mentioned, is one of the most important abstract that is spoken about in the ASCO GI 2022. And the background is that it's a difficult disease, and Topaz 1 is the first global phase 3 study evaluating immunotherapy plus chemotherapy as first-line treatment for advanced biliary tract cancer, and it has reported results. And this is the study design. Topaz 1, double-blind, multi-center, global, very important, phase 3. Eligibility, locally advanced or metastatic disease. It included intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, and gallbladder disease. And then it was stratified on disease status and on the primary tumor location. More than 680 patients. Durvalumab plus gemcis followed by durvalumab maintenance, and gemcis plus placebo followed by placebo maintenance. Overall survival is the primary objective, and secondary objectives are listed here, PFS, ORR, and all that. So my first question would go to Dr. Amol. What is the need to do this with reference to, I'm just trying to relate to the clinical need. Most of my discussion will be trying to harper on clinical applications of these trials. What is the background need? And then therefore, what do you think about this trial design?
Yes, the background need is that, of course, the overall survival or the treatment options that we have available in metastatic biliary tract cancers are limited. In almost last 10 years, they have not found anything which has improved the survival as per the available data. So there is a need. We need to improve the survival. The last trial, which was positive in 2010 NEGM, ABC2 trial. So of course, there is a need, and the study design with a primary objective of OS and secondary objective of PFS seems reasonable.
Thank you, Dr. Amol. This, as Amish mentioned, there was a beautiful couple of trials. One of them is this is a phase 2 trial. This is actually a biomarker-driven study. Basically, this is gemcis durva plus tremelimumab, and there were some interesting analysis of this. And what essentially is that the gemcis durva and gemcis durva tremelimumab is 73% response rate as compared to the previously known gemcis response rate of 50%. So that's very important. But then you also see that gemcis durva is equal to gemcis durva plus tremelimumab. Therefore, they chose the gemcis durva combo as their thing. So this is the statistical design that we have, and it's a kind of hierarchical. Once you have the OS, then you go on to do the PFS, and this is considered as the final formal statistical analysis because overall survival was statistically significant. And these are the baseline characteristics. 300 patients, I'm coming to that, I love you. 300 patients on each arm, so very, very robust numbers, that's what I want to come. So this is the background for this whole setup of this trial, and this is the initial result of the trial or the primary endpoint, overall survival of 12.8 months as compared to 11.5 months, and statistical hazard ratio of 0.80, p-value of 0.021, which meets the cutoff. So that's reported as a positive trial. So Dr. Ritu, your comment on this endpoint, primary endpoint, and this result, does that convince you? What impresses you? And then Amish wants to make a point, but I will first give my chance to Dr. Ritu.
The hazard ratio and p-value, if you just talk about statistics, I'm not too impressed. I was expecting something more with the addition of the durvalumab.
Okay, so you.
If you look at the median OS and if you say it in days, it is exactly 24 days survival benefit.
Okay. Dr. Darshana? Sharmila, I'm sorry. Dr. Sharmila?
Basically, the difference between GEMS and durvalumab and GEMS, to me as a layperson, seems to be very few days, which even Amol has said. But then, as per the trial, it's statistically significant. So if it is going to make a difference, why not?
Okay, so now we'll listen to the, yeah,
If you can go back to the previous slide. I think the important thing here is that, median OS is one thing. I think we should look at the tail end. So the thing is, what is happening at 12 months, what is happening at 18 months, what is happening at 2 years, and you can see the curves are diverging. So that is quite important as well. And the thing is, as time goes by, the thing is, the benefit is becoming more and more.
When you talk about When you talk about the curves we are diverging, we should see that what is been given to a placebo arm in a post-progression. That is also an important factor that one should look at. The control arm is keep on receiving durvalumab. What does placebo arm has received after progression? That is very important before we come to conclusion that the curves are diverging and it is.
Sir, you can go, Dr. Raja will go back to the slide.
Again,
you see in the lowermost, like durvalumab, how many patients are alive at 27 months? In durva and GEMS it's 1, placebo GEMS it's 0. Go.
Yeah.
No, that is not how you read.
No.
Sudeep is there. Sudeep taught me how to read, and maybe Senthil would agree on that. That is not how many people are alive. You see how many people at risk. Means 21, at the 21 months, 24 patients in the experimental arm have reached that state to evaluate. And the 10. So that's why they are not so significant. That is how you read.
There is a lot,
They're eligible for it.
ladies and gentlemen, there is.
Since this point started, so I think all of you are making some valid points, but the reliability of the curve is also important. When the number at risk comes down to less than 50, then that part of the curve is not reliable anymore. So this curve is reliable between 15 and 18 months. Beyond that, one should not go and interpret that purple line up.
We should not look at the tail of the curve.
So that's,
We'll come
since
to.
you started.
Fine. There is a lot more to discuss on these trials.
50 versus 25.
Okay, the numbers. We'll listen to the primary investigator herself, Dr. Do-Yeon Ho, if you allow, actually.
Most important finding is that the overall survival was improved by adding durvalumab on top of GEM6. So the hazard ratio was 0.80. So it means that by adding durvalumab on GEM6 chemotherapy, we can reduce the death risk 20%. That is key finding. And not only the overall survival, but also all secondary efficacy parameters have shown improvement by addition of durvalumab, like progression-free survival also improved significantly, and objective response rate was increased, and time to response was also quicker in durvalumab.
So that's what she says. She's pitching on several of these parameters. We'll come to all of that. So look at the the previous points of interest. Let's go a little deeper into the overall survival. And this is the hazard ratio up to 6 months, 0.91. We talked about it, and I'm still confused on how to take it to the clinic. Hazard ratio after 6 months, and here is the point. At 24 months, you have 24.9% of the patients who are still surviving alive versus 10 points. It's literally the double. And at 12 months, you have 48 and 54, but at 24 months, 24% are still alive and going on. So for me, that looks important, and that's how I will read. And this is the PFS again. At 12 months, you have a PFS of 16% of them are still going strong, and whereas the GEMS is only 6.6%. And look at the response rate. This is very important. There has never been a response rate of about 20 in metastatic colorectal carcinoma. 26.7% response rate, and those who respond continue to remain. So these are all the strong points about this particular, Dr. Rohit, if I can ask you, what is your take based on the original, principal investigator talked about the strength of the trial based on all the secondary endpoints also, and the response rates. What's your take, Dr.
Certainly,
Rohit?
the thing is, this is positive. So basically, these are symptomatic patients. So the thing is, certainly the thing is, a quarter of patients, they are
Symptomatic, that's very much.
symptomatic.
Shailesh?
One thing.
Yeah.
The other thing is we should be looking at, the disease control rate, the DCR.
Right.
And the thing is, how many had stable disease, how many had partial responses. So those statistics are also available, I think.
Shailesh?
Usually these patients present with high tumor burden, and I think this could be a good option for this because the response rate is more. However, looking at the OS difference, whether I'll be using it in my clinical practice is a question.
You have a comment?
Yeah, I'm the second Rohit on the panel. So I'm the second Rohit on the panel.
So I know.
Yeah.
So
I have one point is that 2-year survival rate 24% for gallbladder. It's quite good, and I think we should accept.
So the
way
point
it
is this. Yeah,
and
correct.
the second point I want to make is the curves are diverging after 6 months. So whether we are looking at a maintenance benefit.
Good point. We're going to come to that. We're going to come to that. Thank you for pointing that out. So this particular study, is it going to impact the tomorrow's decision? Of course, cost is taken out of the equation, as all my previous presenters wanted to say. So I'll take that liberty. I'll give you a minute actually. So listen to her pitch again. So she thinks why it is important.
Standard of care is gemcitabine cisplatin. That is the global standard of care actually for first-line advanced biliary tract cancer. This pageant is the first phase 3 study, which is global phase 3 study, to show the overall survival benefit compared to Gemcis regimen. So quite meaningful. So we believe this development plus Gemcis could be a new standard of care in this setting, first line advanced biliary tract cancer. So this result will a practice changing implication.
So that's what she thinks, practice changing. So let's go a little bit more. I'm going to give you all your chance. This is the OS subgroup analysis on all of parameters. Watch that ICC, ECC, and the gallbladder is doing a little poorly as far as only the hazard ratios goes. How to interpret is a different issue. And then also watch the TAP more than 1% and less than 1%. So this is how the TAP is calculated, and the TAP interpretation is very relevant to this particular study. TAP more than 5% is considered to be important for this. So Amol, you wanted to say something.
Yep.
So I request you to comment on this, and also your whether this changes your standard of care or not. So you take your take.
So the first point of the PFS benefit, if you see the Gemcis was proven in 2010 trial, and if you see the PFS arm result of that particular trial, the PFS was around 8 to 9 months. This particular trial, the control arm has underperformed. The trial has not yet published in the full paper.
Yeah, that's
If it is
true.
published in full paper,
Yeah.
I would like to first see why the control arm has underperformed as compared to the historical control. That is the first thing. So the PFS benefit is probably because the control arm has not performed up to the mark. Second, the OS benefit is only 24 days. So honestly, as everybody is saying, in the clinic, I will give the option to my patient, because if you want to live longer by 24 days, and if you're ready to spend, I don't know how much it costs, because I have never given that maintenance durvalumab, and if he agrees for 24 days OS, I will use. Now the third point, whether this will change my practice, answer is probably no, because we have now better options in the chemotherapy. Like there is a trial in which Gemcis plus S1 is given in Japan. The survival is around 15 to 16 months, which is better than this trial's control arm. Plus, there is a phase 2 trial, which is now going into the phase 3, where Gemcis plus nab-paclitaxel is given, in which the survival is around 19 months. So, when I have a better options in the chemotherapy armamentarium, which are less costly, and here more cost and only 24 days OS benefit, I probably may not change my practice.
So Gemcis, nab-paclitaxel, I mean the toxicity.
It's a phase 2 to a
No. We debated over the in the WhatsApp about that. I know that, but you don't argue. There he doesn't want to bring about the toxicity when we add all
have
that.
modified the regimen.
So that's what he debated very hotly on that one. So for here he conveniently chooses. That doesn't matter. But Ritu, would you want to change practice or not?
After that, sir, just one
Yeah,
comment.
please, next, yeah.
Monday morning, we don't have a holiday. So I would give patient option, but I wouldn't change based on this
You would
data.
do. Amish,
Just, median survival, tail, and first 6 months are the concepts which we have now understood very well. Please, Amol, do not tell your patient कि 28 दिन का फर्क पड़ने वाला है. It is the median you are talking of. Entire immunotherapy trial and the ERA would fail if we go on median PFS. So you have to be little smarter than 28 days. I'm sorry, मतलब हम लोग बात कर सकते हैं ऐसे. So don't feel bad. But this is not the way to counsel patients. If there are some students, this is not the way to counsel.
I will change my
I'm sorry,
narration.
you can't do this.
Amish,
I will change my narration saying that, okay, there is a 14% chance that you will be doing better at the end of 2 or 3 years. That is 24 hours. But I don't know whether you will fill in this 24. I don't have any marker also to decide that.
we will listen to some other opinion also for a minute. Volume, please. Volume, please.
TOPAZ-1 study is a landmark study. It is the first phase 3 study to demonstrate benefit of immunotherapy in combination with chemotherapy in first-line setting of biliary tract cancers. In this study, 685 patients with inoperable, locally advanced or recurrent metastatic biliary tract cancers were randomized between durvalumab with chemo followed by durvalumab maintenance versus gemcitabine and cisplatin plus placebo followed by placebo maintenance. The study met its endpoint of overall survival, progression-free survival, and overall response rate. The overall response rate was an impressive 26.7% in the durvalumab group versus 18.7% in the placebo group. Some of the interesting takeaways from the study was the investigators tracked the PD-L1 status on tumor cells, immune cells, and measured TAP scores, which considered both tumor cells and immune cells, PD-L1 together. Interestingly, durvalumab benefit was observed regardless of the PD-L1 expression. This is important to note, considering the fact that biliary tract cancers are considered cold tumors. So it's important to understand that despite the PD-L1 expression or the level of PD-L1 expression, we should offer immunotherapy in combination with chemotherapy to these patients.
That's his take. And he also points out that, adverse event profile, if you look at the adverse event profile, the adverse events leading to discontinuation actually is lesser in Durva plus, at least it's equal. And if you look at the all the adverse events, they are equal between both arms, except of course the immune related adverse events but the discontinuity rate is very, very low. So that's one point. So these are the conclusions of the TOPAZ-1. It's a phase 3, major global, and there is an OS advantage, did not add additional toxicity. And so therefore I'll come to Dr. Sharmila. So would you want to tomorrow advise your patients
I'm a radiation oncologist, but definitely I will believe my medical oncologist.
Yeah, you will believe her, Dr. Rohit. Yeah.
So what I feel is there were 25% gallbladder cancer patients in the entire trial, and the hazard ratio in the subgroup, obviously it's a subgroup.
It's low.
So we have more of gallbladder, technically speaking, but this is an option which should be given to the patient. 2 years, 15% difference. I think a longer survival, I think I would definitely offer in affording patients.
The other Rohit, would you change your practice?
Oh, absolutely. The thing is, an option will definitely give an option.
Yeah, you will definitely give it on. Let's listen to Dr. Richard.
So I think this will be a practice changing. One could argue sort of the modest benefit of adding immunotherapy to chemotherapy in terms of the number wise. But if you look at the coattail of the Kaplan-Meier curve, I think that's where the immunotherapy really benefits, is that they're more long-term survivor with a combination of IO than just chemo alone. And I think that's the key. The second key point here is that if you look at the adverse events, there was not much additional toxicity when you add Durva to Gem and Cis. So I think that's another key too, that you're not adding much toxicity when you add Durva to chemo. But yeah, you're getting some benefit. Once again, if you look at the median number, that's very modest at best. However, if you look at the long-term Kaplan-Meier curve at the coattail, there's definitely an advantage to adding Durva. Other sort of controversy about this trial is that if you look at the Kaplan-Meier curve, the median survival sort of separate after 6 months. So remember, at the 6 months, that's when half the group continues on durval alone, or half just get placebo. So one could argue that this is a more of a benefit of a maintenance durval versus a combination. So that question still has yet to be an answer, but at least there's improvement in PFS and improvement response rate. So I think based on the TOPAZ study, there will be a change of our practice in the future, where.
So that's the point. He touched upon the point that was raised, whether it is a maintenance effect or whatever. So I had a patient. This patient was seen in October 2021, before the TOPAZ was actually published. But we were privy to the Meditime data, and we were in touch with the lead investigators here, and we were fortunate to connect with Dr. Yon O. And this is a doctor, therefore we had to work a little extra hard. Advanced metastatic disease. And he again had a very interesting NGS profile. That's a different discussion. But this patient was put on gemcitabine durvalumab, and he is in near complete metabolic response, and he is now on maintenance durvalumab with us. So this is one of our very early patients, and I just want to say that he is doing very well. Very, very excellent symptom control and very, very good complete response he is on. He has already crossed 8 months with us. So for want of time, we'll move on to the next study, BRAF mutations, and therefore the Beacon study impact. Dr. Sailesh, what is your current take about the BRAF mutations and CRC, and what is the need to do this study? How important and relevant in clinical practice? This is the Beacon study, which tries to look at the use of binimetinib, Encorafenib, Cetuximab. They did a safety lead-in, that's about 30 patients, after which they went on to do the phase 3 trial. These are the 3 arms, and the investigator's choice were FOLFIRINOX chemotherapy plus Cetuximab, and doublet and triplet. That's the design. So what is the need, and your comment on the design?
So we all know that BRAF positive metastatic colorectal cancers, they do very poorly on the treatment. Most of the time we use frontline as FOLFIRINOX plus BEV as a first line combination. So if you look at the second line and onwards, so there are hardly any drugs which are remaining, and especially when you know that BRAF is mutated, only using a single agent, single drug Cetuximab with chemotherapy has a very poor response rate as well as the overall survival rate. So if you look scientifically, the response to BRAF inhibitors in colorectal cancers using only BRAF inhibitors is not really good as compared to what we see in melanomas, where you get 60 and 70% response rates. So the scientific reason behind adding Cetuximab is because there is an upstream regulation of EGFR. So combining both the drugs has shown a better response. So maybe that is the reason why both the drugs are combined in one of the arms. And obviously would be a very good option, especially when the 2 drugs used here, and the BRAF inhibitors and the Cetuximab is chemo-free regimen. So the tolerability and the response rate and the OS is good in this arm.
Yeah, you're spot on, Sailesh. Thank you for bringing out that EGFR amplification. I'll go the reverse way, if please permit me. Rohit, what is your take on this design and the relevance for patients with BRAF mutated CRC?
I think I've got nothing to add. Sorry.
Thank you. So we'll listen to the original investigator himself, Tabernero. So he wants to say what exactly Sailesh wanted.
Initial data suggested that as these patients had a BRAF mutation, actually they could be sensitive to BRAF inhibitors, like for example, patient with melanoma. But actually with the initial data, we realized that the activity was really very low, almost inexistent. And then we tried to understand in the lab which were the mechanisms of immediate resistance to BRAF inhibitors. And we realized that there was an immediate upregulate of the epidermal growth factor receptor, EGFR. So then we went back to the clinic and we decided to do the Beacon study.
That's the reason, as Sailesh pointed out, this is the EGFR amplification they are trying to answer. And this is the data set. 200 patients on all the arms, control arm, and doublet, triplet. Let's see what happened. This is the primary endpoint. Triplet and doublet both were looked for the primary endpoint, overall survival. The median overall survival was 9.3 months for the triplet, and for the doublet also it was 9.3 months. Control arm was 5.9 months. So the hazard ratio was 0.60 for the triplet, and hazard ratio for the doublet versus control was 0.61. The overall response rate was 27% for the triplet, and doublet is 20%. The control arm, that is the chemotherapy plus cetuximab alone, is only 2%. So that is the overall survival and the overall response rate. So what would you do with this data? Now, how much would you be influenced in your practice?
So I think this is a very good combination in the second line and beyond. I would obviously not use the triplet. I think there is quite convincing data for the doublet that it works. There have been some suggestions that the triplet works better if there is more than 3 visceral organ involvement or maybe high CRP or certain subsets. But essentially, there is significant more toxicity, diarrhea, dermatitis, acneiform rash, etc. with the triplet, without any gain in survival. So I would be convinced using a doublet in this setting.
We'll come to that. Dr. Ritu, what would you want to do with this data?
Yeah, this is a very good data. And as I agree with Rohit, I would prefer to have a doublet rather than a triplet.
So doublet versus triplet. So we'll come to that. So Amol, I'm going to come to you. So this is the OAS, particularly the subgroup, and this is only for the triplet, but if you look at the doublet OAS subgroup also will look the same. So I didn't want to put it across. Let's listen to Dr. Taberno on his doublet triplet argument, and then I will come to you. Listen to him.
The triplet combination did much better than the control arm. So the hazard ratio for overall survival was 0.52, translating the median survival from 5.4 months in this poor risk population to 9.0 months for patients that received the experimental treatment. Also, we look at the data on the doublet and we compare the doublet with the control arm, although this was not one of the primary endpoints of the study. And there was also benefit, slightly lower, with a hazard ratio of 4.60 and the median survival increasing from 5.4 to 8.4. But more importantly, as these patients are really very symptomatic when they have advanced disease, and also we show an important advantage in the overall response rate. So the overall response rate for the triplet was 26%, independently reviewed. For the doublet, it was 20%, and for the control arm, it was only 2%. But even more, in looking at the tumor shrinkage, according to the waterfall plots, patients receiving the triplet treatment tended to benefit more than those that receive the doublet.
So that's what he says. Look at the overall response rate, look at the tumor shrinkage, and that's superior in the triplet. So doublet versus triplet, your take?
No, obviously if the PFS and the OS are more or less same for doublet and triplet, we would like to go for the doublet only. And I'm not so sure what was the rationale for studying the triplet to begin with, because that particular thing has only worked in melanoma, that also in certain subsets. The other drug, that is the third drug in the triplet, has failed already in ovarian cancers and other solid tumors. So probably they wanted to see whether maybe there is some advantage of doublet over triplet. That's what was studied. But at the end of it, if the same as triplet,
I'll definitely come to the rationale of the triplet in a couple of slides. But Dr. Sailesh, what's your take on the doublet versus triplet control? You see that?
I think the study was, it was an open label study.
Yeah.
And if you read the patients which were randomized but who did not go on to the study were quite a large number of patients, because I think they probably knew that this is not going to work, the cetuximab plus chemotherapy. So I think there are around 20 or 22 patients who were randomized but did not went on to take the treatment. So I think it was probably, the hypothesis was so strong that it is going to work.
What Shailesh said, I wanted to point that out, that the very fact based on which they have decided this precision-based treatment, that if you block BRAF, EGFR would be activated and vice versa. Control arm, there should have been a choice of bevacizumab rather than cetuximab. Although people might have taken first line.
Amish, I'm coming to bevacizumab question. Thank you. So we are still staying for a minute on the doublet triplet. And so this is again was presented by Dr. Scott Kobetz in the ASCO. And this is the updated, here again, he reinforces the doublet triplet curve is actually superimposing on each other. And if you look at the PFS, everything is very similar except the overall response rate, okay? But the doublet triplet question is not that simple. Let's hear a counter argument to that, okay? So here from Dr. Don Aderka, he's from Israel, Met Sheba Hospital.
In the Beacon study, we observed that the doublet and the triplet of the combinations are equally effective. They gave us 9.3 months survival. Now, what was our concern? We know, for example, that bevacizumab that is administered in the first line can interfere with the effects of cetuximab or EGFR inhibitor that is given in the second line. Because in this study, in the first line or second line, patients were given either chemotherapy alone or chemotherapy plus cetuximab, bevacizumab. Then, because of the long half-life of the bevacizumab that can be more than 6 months, then it could be an overlap between the bevacizumab administered in a previous line and the cetuximab that was given in the doublet.
So that's his argument. It's not just a hypothesis. He went on to do a paper presentation in ESMO 2021 with Eric Van Cutsem and Joseph Taverneau, Don Edgar's paper. And this is on the effect of prior bevacizumab. Look at this. And he says that whenever prior bevacizumab is used or not used, then you have the best effect with the triplet. So he says that if there was no prior bevacizumab and if there is at least there is no gap of 4 to 6 months, then the triplet is going to work better. So that's very important, because based on this, he would recommend that in BRAF mutated patient, it's not a good idea to use bevacizumab in the first line setting. So just listen to him for one more time.
And the doublet 10 months, so another 2 month difference. I believe that in a study that will be devoted for such an examination, we can see that the triplet is probably better than the doublet in the absence of previous bevacizumab.
So that's the point. It is not just that simple. You would also hear similar arguments from Dr. Eric Van Cutsem himself. But, this is a little bit difficult because his English is very difficult to listen. But he also goes on to say why the doublet and triplet equation is not that simple. He has various other biological parameters to explain the point. I'll try to make it here. So he says this. If I can get some volume.
Two experimental arms were better compared to chemo. The triplet was not better compared to benefits from a triplet versus a doublet. At prior types of treatments, the BRAF target types in this situation. And what was indeed seen is that patients with the CMS type 4 and the biomarker type.
So that's what he is arguing, that it's the prior therapy of bevacizumab, prior the types of chemo that you use, and then CMS4 and BM1 subtypes, and then he also brings in the MAP kinase. I mean, of course, Van Cutsem is literally the god of colorectal. So now your take on a mole on this deep dissection and trying to make some sense of it. You may not agree, but what do you take about this?
I just wanted to ask, have they done a predefined subgroup analysis of those who have received prior BEV versus those who have not received prior BEV?
Now they are. So
it was not a predefined subgroup analysis?
No. These are all just retrospective thought process. So that's where it is. Now we had a patient. Let me illustrate the point here. This is a 58-year-old patient and has a BRAF V600E patient. And this is the NGS, and this is the IHC, PD-L1 negative, HER2 negative, MSI normal, and again IHC BRAF V600E positive. This patient your question about if you see how BRAF has been treated, you always need the MEK inhibitor because it's a downstream inhibition. So BRAF inhibition, MEK inhibition, and then you have the escape with EGFR. That's how they had the panitumumab, and there's a whole biology of whether it worked out well or not. It's a different question in this particular trial. That's the whole biology of how things are done. This is the EMA currently, and the European approval and also the FDA approval is for the doublet at this point, but these are other guideline approvals for the triplet. And there is a paper on the triplet with dabrafenib, trametinib, and panitumumab in colorectal cancer, and that's a paper. For us, it was interesting because these are the drugs that were available in our country, and therefore we had put this patient on dabrafenib. I mean, he had progressed on first line. He had voluminous disease. Look at the volume disease, extensive disease in the abdomen, very voluminous, very symptomatic. We had put him on dabrafenib and trametinib and panitumumab. Look at the response. Amazing response, amazing symptom control. He went on to have a PFS of 9 months. So that's the point. So that's the answer to your question, why they would want to do a triplet. Taking this further, there is another young lady. She is 38-year-old and she had a BRAF V600E, and she is again, MSI normal. That's very important. That's a different subgroup of patient, and immunohistochemistry positive. And this lady, this is the excellent response to first-line chemotherapy in November 2021, and she was put on bevacizumab at that point, and then completed an ongoing response. This is in January 2022. February 2022, she goes home, and then in April end or May early, we hear from her that she has already progressed. So based on that, we had a heartburn. Whether we should have done something different, whether we should have put her on first line with any of these drugs, would that make a difference? This is the anchor data. I think Amish touched upon this. This is the first line of the triplet in BRAF V600E mutated patients. And you see that the PFS is still very modest, but the response rates are very, very high with the first line. It's above 50 to 60%. So we had this question, whether we should have done. So I had tweeted on this, and I had put this on the Twitter, and this is the response I got from Pashtun Kasi saying that, we don't know yet. However, this is what BRAF V600E does, whether Bacon or Oncar, the median PFS is still around 4 to 5 months. So your patient did respond to chemo. It's more about continuum of care. And Breakwater is another trial he pointed out. Breakwater is chemo plus the same triplet, and you look at the response rate for Anchor in first lines, 50%, and whereas the response rate of Beacon is already 27-28%. The PFS is nothing. So wherever you go, you are stuck, and this is where the world is going. So your comment. Now we'll come back to you, Aman.
I think that's what I was trying to say, that the next step will be the Breakwater, in which they will combine doublet with the chemo, and now there are studies with doublet plus IO also going on. So probably that will be.
Yes, that's a NCT trial in which the doublet, in which nivolumab plus cetuximab plus Encorafenib. That's another trial. In fact, I first wanted to discuss that, but that paper was also presented in ASCO GI 22, but we thought it's a small paper, too early, too radical, so we thought we'll come to that. So Amish pointed this, so I took upon this one. Silas, what do you think actually?
This combination is definitely promising. I mean, like said, probably come in first line, or maybe I don't know whether adjuvant also with such a situation. So I would definitely go for the combination.
You will go for the combination. And so Ritu, madam, would you want to now choose this doublet or triplet? You would definitely use it if the patient progresses on first line, correct?
Yes.
So that's what you agree. So any other comment about this particular trial? Because I want to move on to the PRODIGE, because I really want to be giving some chance to our radiation oncologists to participate. That's why I brought this into the third. Okay, so we'll go to PRODIGE. And again, a very important question, whether PRODIGE would influence in the way we want to treat the locally advanced rectal cancer. Particularly, do we want to aggressively take up the neoadjuvant chemotherapy along with CTRT, because currently CTRT is the standard of care. So this is PRODIGE study design. FOLFIRINOX, followed by concurrent CTRT, followed by TME, followed by adjuvant chemo, and versus the standard of care, concurrent CTRT, followed by the standard surgery, followed by, so that is the study design. And again, very good study, 200 plus patients on both the arms. Baseline characteristics are well balanced, and particularly the T3, T4, 80% T3. And this is very important, compliance. FOLFIRINOX, 91% of them could complete that. Radiotherapy, 98% of them could complete that. And then adjuvant therapy also, 80% tolerance. The whole question of this trial will boil down to tolerance. And this is the survival data, DFS for the neoadjuvant FOLFIRINOX. And this is the overall survival. And this is the metastasis-free survival. So with that, I would come to Dr. Rohit. So should I now consider total neoadjuvant chemotherapy in patients with locally advanced rectal cancer, T3, T4, nodal positivity, CRM threatened, and one more indication, lower rectum, close to anal. So what is your thought on that? Yes.
So the thing is, this is quite a positive trial. So basically, the thing is 91% compliance with FOLFIRINOX is a very, very good thing. So the thing is, I think they've done a couple of things. So the thing is, when you look at the original regime, 85% there was grade 3, grade 4 toxicity. And the thing is, in this regime, they've done 3 things. They have restricted the use to young patients less than 76. They've targeted use of GCSF has been done. And the third thing is they've got rid of the bolus 5FU component. So because of this, the thing is they've been able to get their grade 3, grade 4 to less than 17%. So that is quite a good thing. So yes, the thing is, PNT is quite now the new norm, the new standard of care. The thing is 35 centers in France have done this. So very, very uniformly treated. A very, very good coordination between the treatments. And the thing is, what they've done exactly is, they've got this, quite early on. And the thing is, the good PCR response rates are also quite good. Almost 28% versus 12%. So they're all quite positive and all quite good parameters that are seen. Here you can see the separation of curves taking place quite early. Just at 3 months, you can see the thing is the survival curves, the PFS curves are all separating.
Yeah, you are spot on with regard to the PCR. Conventional CTRT, this is our own data, one of our DNB students' thesis. This was presented 2 to 3 years ago. Our CTRT rectum and PAT-CR rate, TRG0 is 18%. But of course, it could be anywhere between 12 to 18% different institution. That's the point you made, very, very important. Sharmila madam, what is your take on this actually?
Sir, I would agree to what points you said right in the beginning. It's not for every case of T3, T4 that we will be taking it for TNT. We need to choose the patients. We cannot take patients who don't have bulky disease, who don't have lot of nodal disease. This FOLFIRINOX regime is ideally for bulky T3, T4s where there is extramural vascular invasion, where MRF is threatened, where there is lot of nodal burden regionally, and there is a chance that there can be distant metastasis later.
Is there a concern about toxicity, Dr. Amol?
I have presently a patient who is undergoing treatment, who has completed 4 cycles of FOLFIRINOX followed by presently on CTRT. What I have realized is capecitabine has been an issue. I have not been able to give him for last 3 weeks because of the leukopenia, and especially neutrophils as well as lymphocytes, both are very low.
Amol, you want to say something?
See, regarding the design of the trial, or the few points that I want to say is that basically the good point of the trial is that the post the adjuvant treatment is fixed everywhere. So basically what they have done is that they have added irinotecan. That is the additional thing. Otherwise, everybody has got more or less the same thing.
Yeah, you are very right. You will hear similar.
So let me complete. Now there is no OS benefit as seen in that OS trial. So whether PAC-CR in rectum leads to improvement in OS, that is not yet shown, and in meta-analysis shows that it doesn't show improvement in OS. And so what exactly are we achieving by giving an irinotecan addition? I'm not aware. And second thing is that if you look at the numbers, the number of T4 patients, the low-lying rectal tumors are hardly 18-20%.
That's what you get in real life.
But if you see a similar trial of the similar design, which was done in Poland, in Polish trial, which has come as negative. In the same paper also.
They didn't do FOLFIRINOX, I suppose. I'm not very sure.
So the Polish trial was negative because they have predominantly those kind of tumors which are high risk. Also not showing any OS.
We're going to quickly come to Rapido. Allow me, please.
Also not showing the OS benefit yet.
This is one of the principal investigators.
And the last point is
the primary endpoint of disease-free survival. Regarding the main outcome, treatment with neoadjuvant FOLFIRINOX improve the 3-year disease-free survival, improve the metastasis-free survival. The absolute gain was 7%. Importantly, the odds ratio was 0.64. So for the first time, PRODIGE 23 improved the survival for locally advanced rectal cancer patients. Importantly, the pathological results were also improved since 27.8% of the patients achieved complete pathological responses. Neoadjuvant FOLFIRINOX did not impair the safety or surgery or the quality of life. Patients treated by neoadjuvant chemotherapy had an improvement of the overall global quality of life, and we observe less impotence in men. So in conclusion, PRODIGE 23 is a practice-changing clinical trials, improving the survival of locally advanced rectal cancer patients.
Rohit, what would you wanted to say something?
Yeah, so basically coming to the survival, overall survival. So basically the primary endpoint was a 3-year DLS. So that is one thing. Number two, the thing is, if you look at the OS, the p-value is 0.07. And the thing is, there is the analysis that the thing is, with more mature follow-up, the thing is at 5 years or so, we are expecting a slight,
as of now, it is not significant.
5 years. We don't have that data as of now.
As of now, it is not significant.
One comment only. Should we actually talk about TNT in this because adjuvant therapy is being given?
Sorry?
Will this trial be considered TNT when adjuvant therapy is being given? So it's not like Rapido, right? Everything is not being given early.
You are very, very right. You are very, very right. But we are trying to put this into context. You are very, very right. This is exactly the point. Yeah, please go ahead.
If you use irinotecan also upfront, if you use oxaliplatin also upfront, what are we going to give in relapse in the chemo boom? Chemo back. Those who are going to relapse, what are we going to do? The rationale is that if it is making a difference in OS, you use everything upfront. Otherwise.
So I'll ask Dr. Sharmila. And everyone wanted to compare this with the Rapido. That there is always a burning question: short course RT, and then followed by chemo, or it's a neoadjuvant chemo followed by CTRT, and the organ preservation rectal OPRA trial, and all of they have tried to sequence, and the sequence is clear. At least this OPRA trial says that RT followed by chemo is better than the chemo followed by RT. So we know the reason why. You will talk about it. Just 2 more minutes. We'll cut off the last trial. Dr. Sharmila, your points.
I'm not sure whether RT followed by chemo is better than. I still feel that chemo RT together is the standard of care.
No, that's what OPRA says.
As per what OPRA says. What I feel is this TNT, the PRODIGE 23, might become after some time the standard of care in select group of patients.
Volume, please. Okay, the volume is not here, but basically he argues the same point as one of them pointed out. This is nothing but giving more chemo upfront rather than being pure total neoadjuvant therapy. So there are now 3 strong trials that talk about total neoadjuvant therapy in one way or other. And the reason that OPRA said whatever it said is that the longer the time duration from the radiation to the surgery gives the best path-CR rate. So that's the reason why that particular sequence has helped. So because you are closer to the surgery with your RT later on versus, so that's the reason, that's the argument. So with that, I think probably we won't have time for the fourth abstract. I'll stop there, but I will now open it for my panelists on this particular question. In all of them, I'm going to ask, would they want to go the TNT way for all their rectal or not? I'm trying to take a vote here. So I'll begin with
I'll point to another important aspect. So basically the thing is, when you look at the primary endpoint, so the thing is how, when they design the trial, so they design the trial assuming that they would be improving the 3-year DFS from 75% to 85%, a 10% increase in 3-year DFS. But actually what happened is the 3-year DFS was 69% versus 76% or so. So the thing is, it was 7%, but still statistically significant p-value was 0.03.
Sailesh?
Encouraging, yes. In younger patient, definitely would like to do.
So what is your take, Amol? You want to do it in some way or not?
Probably no.
Probably no. Okay.
I agree with Sailesh. For younger patients and a select group of patients, this is one of the good options. I'll do it.
Sir, I've already told.
You have patients on that.
So Rapido had worse patients with the actual TNT. I would prefer Rapido than this.
Rapido, short course RT. Fine. So that's their opinion as they stand. So with that, I really thank you for your opportunity, Amish. Thanks so much. Thank all my panelists for thanks. Sir.
We have advice for yes.
Good afternoon, everyone. I'm standing between all of you and lunch now, so I'll be brief. So we've always dreamed of the poster boy of immunotherapy and precision medicine being lung cancer, and now we are looking at the last 2 years. Most of the papers all across ASCO GI, ESMO GI, even ASCO, more and more papers coming out on GI malignancies and trying to focus on specific subset of GI malignancies, and that's what we've really had a wonderful time listening to all of these 4 papers. Of course, trying to select out patients, trying to improve the outcomes always remains our goal, and that is what we've done here. I think the discussion about the total neoadjuvant therapy and the PRODIGE 23 is very, very interesting in our perspective, because in India we do get to see a lot of young rectal cancer patients, those who present with T3 and above and node positive disease. The most encouraging data comes actually from one of the study, which is the Himalayan study, which actually gives us an opportunity of using a non-VEGF option for patients with HCC, where the bleeding risk can be tackled with this option, giving a similar kind of results as what the current standard of care of atezo-bev is. So this is something which will really be an encouraging thing, where we can use a completely non-VEGF TKI or a non-VEGF monoclonal antibody option in patients who are at high risk of bleeding. So that opens. I think most of the other points were very well discussed on the panel, and I would end here. Thanks.